So if there are no comments, let's move on to the final presentation. V.S.Jibia is a young lady, unfortunate young lady, with a double whammy of an inherited disorder of uncertain nature, on top of it an acquired kidney disease.
Good afternoon, everyone. I am presenting a 15-year-old young lady. To start with, her birth history. She was the second born out of a third-degree consanguineous marriage, born out of normal vaginal delivery. It was a prolonged labor and the baby did not cry immediately after birth. She was in hospital for a period of 10 days. There was no history of any neonatal seizure or jaundice. At 2 years of age, the child was evaluated for developmental delay. She had social smile at 8 months, head control at 6 months, crawling at 1 year, walking without support at 1.5 years, and significantly the parents noticed that there was a delay in speech for which she was mainly evaluated, and during the evaluation they found that she had hearing impairment. And again she was advised more investigations, but then they were lost to follow. In 2016, that is at 9 years of age, she was admitted with complaints of swelling of legs and cola-colored urine. On evaluation, she had hypertension with a blood pressure of 130/90, severe anemia, hemoglobin 5.5 grams, count 6,500 and thrombocytopenia. Her creatinine was 0.6 and albumin was 3.2 gram per deciliter. Urine examination, albumin was 1 plus with active urine sediments, RBCs were 10 to 12 per hyperfeed. Her C3 was normal, however ASO titer was positive. So at this point of time, she was managed as a case of infection-related glomerulonephritis. Because of her hearing impairment, she underwent a brain evoked response audiogram which showed bilateral sensory neural hearing loss. The child also had diminished vision and she was diagnosed with retinitis pigmentosa. She also had hepatosplenomegaly. Retinitis pigmentosa and renal disease, as we all know, it is associated with nephronophthisis. In senior Logan syndrome, there is corticomedullary cyst with retinitis pigmentosa. In Joubert syndrome, cystic kidneys with hepatic fibrosis, polydactyly, cerebellar ataxia, nystagmus, and retinitis pigmentosa is noted. Again, in Bardet-Biedl syndrome, there is obesity, postaxial polydactyly, cognitive impairment, and retinitis pigmentosa. However, the child did not fit into any of these. She had severe anemia and actually it was a bicytopenia, so further evaluation was done. She had severe iron deficiency anemia with a T-set of 3%. Peripheral smear showed anisopoikilocytosis. A bone marrow evaluation also was done at that point of time, but it did not reveal anything significant. So the child was advised karyotyping and further genetic studies and an MRI brain, but they were lost to follow up again. So in last year, at 15 years of age, the child presented to us with complaints of fever for 3 days, facial puffiness and swelling of legs, cola-colored urine and renal failure with a serum creatinine of 1.7 mg per deciliter done outside. So on examination, the child had dysmorphic facies, low-set ears, flat occiput, open mouth with tongue thrusting, multiple infected acne and saddle toe. On examination, she had severe pallor, bilateral pedal edema, blood pressure of 160/90. She had hepatosplenomegaly and fundus showed retinitis pigmentosa. At this point of time, after examination, our first differential was an infection-related glomerulonephritis. On further evaluation, she had pancytopenia, hemoglobin of 4.5, counts 3,700, platelets 73,000. Coombs test was negative, peripheral smear showed microcytic hypochromic anemia, creatinine was normal by then 0.6, severe hyperalbuminemia, and there was prolongation of both PT and APTT. Urine examination done showed urine albumin 4+, and it was active urine sediment, RBCs 20 to 25, and urine PCR was 5.6. She had low C3 and C4 level. So with pancytopenia, low complements, coagulation profile abnormalities and acute nephrotic syndrome, could it be lupus? So we did an ANA which showed 3+ speckled pattern and anti-dsDNA was more than 800 international units per ml, but we could not biopsy her at that point of time because she had prolonged PT and APTT and also significant thrombocytopenia. So we started her on pulse steroids followed by oral steroids, and her pancytopenia and proteinuria started improving. So we also did an ultrasound which showed hepatosplenomegaly. An MRI brain was done which was normal. So then we did a renal biopsy. This was after her thrombocytopenia improved. Under FFP cover, a renal biopsy was done. IF showed C3 3+, IgG 2+, C1q 1+, granular positivity on the capillary loops and focally on the mesangium. Light microscopy showed 6 glomeruli which were enlarged and hypercellular with endocapillary proliferation. A diagnosis of endocapillary proliferative GN, possibilities of either lupus nephritis and IRGN was made. So this is the light microscopy, PAS and silver stain both showing endocapillary proliferation, and IF showing C3, IgG and C1q positivity. So we did an EM because again there was a diagnostic confusion of lupus versus an IRGN. In the EM there were subendothelial and mesangial electron dense deposits with focal effacement of the visceral epithelial foot processes, and there was no subepithelial humps noted. Tubule showed electron loose and vascular inclusions in the cytoplasm. So the diagnosis was SLE with lupus nephritis, and she was started on immunosuppression. According to her weight, MMF 500 mg BD was started. But still the child had hepatosplenomegaly, pancytopenia with sensorineural hearing loss and retinitis pigmentosa. So are we missing something? So we went ahead with a bone marrow biopsy for this patient, which showed a cellular marrow with tri-lineage hematopoiesis, and there was increased macrophages with abundant amphophilic cytoplasm, which was PAS positive. So we thought if it could be some storage disorder, and Gaucher's was one possibility. So we did a dried blood sampling, though it is not very sensitive and not very specific. We did the screening test, and the beta glucosidase enzyme assay was borderline low. So to confirm, we did a clinical exome sequencing, and the clinical exome sequencing, surprisingly, there were 2 mutations. One was NPC1 mutation, which causes Niemann-Pick disease type C1 and Niemann-Pick disease type D, and the second mutation was PEX1, which causes peroxisome biogenesis disorder 1B. However, both were reported as uncertain significance. So the first is about Niemann-Pick type C1 and D. It's also called childhood Alzheimer's. Mutation is in the NPC1 and NPC2 gene. It affects 1 in 1.5 lakh population. The NPC1 gene basically codes for the proteins which are located in the membranes inside the cell, which are required for the movement of cholesterols and lipids within the cell. So abnormality in this can cause buildup of lipids within the cell, and this leads on to all the abnormalities. So clinical manifestations are usually hepatosplenomegaly with more of CNS symptoms like cerebellar ataxia, dysarthria, dysphagia, epilepsy, progressive dementia, progressive hearing loss and psychosis. Progressive neurological disease is the hallmark of this syndrome. There is no specific treatment and there is only supportive therapy. So this is genetics of Niemann-Pick. The more common is acid sphingomyelinases deficiency. That is what we call it as Niemann-Pick type A and B. However, this child had she had mutation in NPD type C1 and D, that is NPC1 gene mutation, which causes NPD type C1 and D. Next is about peroxisome biogenesis disorder. So it is basically a spectrum of disease which is called as peroxisome biogenesis disorder. It includes mild variant like infantile Refsum disease, intermediate of neonatal adrenoleukodystrophy, and severe form, that is Zellweger syndrome. So here basically there is dysfunction of the peroxisome. So as we all know, peroxisome is required for the oxidation of very long chain fatty acids and branch chain fatty acids. So there is deficiency, when there is a dysfunction of this, there is accumulation of very long chain fatty acids, and this leads on to the disease. So usually in peroxisome biogenesis disorder, in the milder forms, the children usually grow up, they can walk independently and communicate. A striking feature here is craniofacial anomalies in this disorder. And leukodystrophy usually develops later, and they develop psychomotor retardation later. And most striking manifestations here are sensorineural hearing loss and retinitis pigmentosa. So what is the link between these disorders and SLE? So there are not much literature evidence for storage disorders with SLE. So there are two case reports, one on Niemann-Pick and one on Gaucher disease with lupus. So the theory proposed here is that there is dysfunction of lysosome. So lysosome is required for autophagy. So when there is these apoptotic debris, when they are not cleared off, that can be a trigger for lupus. So that is the hypothesis which is proposed behind storage disorder and the link with lupus. So there is one more case report on Gaucher disease and lupus. So this is one experimental article which says the defects in lysosomal maturation facilitate the activation of innate sensors in systemic lupus erythematosus. So this may be the reason why in lysosomal disorders there is activation of the innate sensors and that leads on to lupus. However, we could not find any evidence for peroxisomal disorders causing lupus. So in our patient, there are more factors which favor in terms of peroxisomal biogenesis disorder than Niemann-Pick's. Basically because she has these striking features of craniofacial abnormalities, sensorineural hearing loss and retinitis pigmentosa. So the final diagnosis is SLE with lupus nephritis and an underlying storage disorder. So she is currently in follow-up with us. She achieved partial remission, came to a urine PCR of 0.6. But however, in the last visit, her creatinine is 0.8. She has a relapse, urine PCR of 4.6. 24 hours urine protein is 4.4 gram per day. Both C3 and C4 are low and anti-DS DNA is negative. A repeat renal biopsy is deferred in view of persisting thrombocytopenia. She is continued on tablet MMF, prednisolone, and we have uptitrated the ARBs. Thank you.
So even after all the extensive investigations, actually, we are not sure as to, there are certain features, very few features in favor of Niemann-Pick. Actually, more in favor of the biogenesis disorder, peroxisome biogenesis disorders. That's what I think, but there's an anecdotal case report of pathophysiological link between Niemann-Pick and lupus. But that doesn't make, that doesn't push us to think in terms of Niemann-Pick in health. Most of the things will fit into Niemann-Pick's actually. And again, if the SLE flare goes up like this, what we are going to do subsequently, how to manage and all that. So this is more of academic excitement. On the philosophical note, I still wonder like, why a 15-year-old girl should suffer with such severe diseases and how to take care of them. And I take this opportunity to thank all my registrars. They are so young, but they are also empathetic. Sometimes in the rounds I say no, because all the 3 floors are full and 35 patients are waiting in different wards to be taken in. Sometimes you feel that these patients can be given a lesser priority. You think of something that they will not listen to me. So that's it. Today's philosophical note I had. Any comments?
Given the extensive cataloging of genetic disorders, I think by Cusick or somebody, there is no mention of this particular combination. No, genetics.
How to go about First of all, you don't have great knowledge about these diseases.
I know. Nobody has, probably. Why this association? Reported that.
And it's not just this actually. Why I made this last statement is that we have a series of Bode-Biedl and so many other Lowy syndrome. You name anything we have, and all those patients are on CAPD, maintenance dialysis. And the parents are very particular, they are very caring, and it's very difficult. We have to kind of stand away from this philosophical and emotional aspect and treat. Looking at the parents, looking at the parents' side, I really adore them. We have to salute them. The kind of patience they have, the kind of resilience, bringing such children regularly for all that. We have one bipedal young boy, he's on CAPD. Ended up in CAPD peritonitis and again searching for other access. Okay. That's so many. Thank you, sir. I thank one and all for making it participating. Thank you so much. And Dr. Jaji Abraham has sent a note saying that he would like to host the next edition of City Nephrology Meet at MGM hospitals. I don't know the date, I will communicate later on, sir. And April? 29th April, MGM hospitals. Thank you so much.